Welcome to PD Exchange, our peritoneal dialysis podcast. This is our first episode, and I am absolutely thrilled to be here with Jeff Pearl, Rob Quinn, and Danielle Fox. Jeff Pearl is a nephrologist and editor-in-chief of PD International, and my co-host. And I'm Nikhil Shah. I am a nephrologist in Edmonton, Canada, and the social media editor for PD International. Today, we are discussing a recent original article from the July PDI issue. The article is The Availability of Support and Peritoneal Dialysis Survival, a Cohort Study. And I am very pleased to have the first author, Danielle Fox, and the senior author, Rob Quinn, on the podcast. Danielle, do you want to say a few words about yourself?
Yeah, thanks very much. And thanks for having me. I'm really excited about the new podcast and all the episodes to come. Again, my name is Danielle Fox, and I'm a PhD candidate in the Department of Community Health Sciences at the University of Calgary. And I also work as a registered nurse in a peritoneal dialysis clinic in Alberta, Canada. Pleasure to be here.
Thanks, Danielle. Rob, do you want to go next?
Sure. So I'm Rob Quinn. I'm a nephrologist and health services researcher in Calgary, Canada.
Perfect. Thank you so much, both of you. And without further ado, Jeff, take it away, please.
Thanks, Nikhil. And so it's really exciting to kick off the inaugural PD Exchange and really a great article to start things off with. So Danielle, I'm just going to ask you, tell me a little bit about where the concept for this research study came up, and tell us a little bit about how this study came to be.
Great question. So as I mentioned, I'm a nurse. I work in peritoneal dialysis. And more recently, I've been doing research on improving care experiences and outcomes for people who are doing their dialysis at home. And in my work, I really saw the importance of social support and how important it was to meet people's needs. And of course, realized how critical family was in making that happen for people. And I think that, even though it was highly realized and valued by the healthcare team, it was often not kind of captured or included when exploring the risk of transferring to hemodialysis. And so, of course, Rob and I wanted to seek out to kind of change that and explore that from a more quantitative lens.
Great. And so this is just like, I'm a nurse and I'm going to do research?
Yeah.
Okay. Oh, no, that's fantastic. And then maybe, Rob, give us the details, Rob.
So Danielle, I first met as a clinical nurse, but then co-supervised her for her master's work, where she did some really great work in home dialysis, both qualitative and quantitative. And then I pressured her into being one of my students as a PhD student. So she's got a fair bit of epidemiology training. So she comes at this from both the research lens as well as the clinical lens.
Okay. And Danielle, have you completed your PhD?
No, not yet. In progress. getting there. Slowly working through the research.
Please keep us posted. Very exciting. All right. Maybe, Rob, a question for you. For those people listening who aren't as familiar with the study, and please read PDI and read this study in detail, but can you give us a little bit of a synopsis about what the study was and what the study found? Can you describe that a little bit for us?
Sure. So, as Danielle alluded to, we've been kicking this idea around about, how could we look at support and its impact on outcomes in PD patients? We had been running a quality improvement initiative provincially where we had the luxury of capturing data at baseline, very granular data around the PD assessment. And part of that was assessing the social supports that were available in the home. And so prospectively, we collected that data. We really hadn't done anything with it. And we decided that we would use that data set to try to examine this question. So basically what the study did was look at the availability of support, defined as having somebody in the home who was kind of able, willing, and capable of helping with PD or the associated kind of tasks. And then looking at its influence on technique survival. And kind of the Nicole's notes, Danielle can elaborate on this, but was that we found that it was time dependent. So support didn't seem to have much of an effect in the first 3 months, but between 3 and 12 months, there was a significant association with the kind of risk of technique failure and transferring to hemodialysis. And then again, it seemed to wane after 12 months. So there's this critical period between 3 and 12 months where support seemed to be really important in terms of keeping people on therapy.
So if I understand correctly, the people who had support on PD were less likely to transfer between months 3 and 12 to hemodialysis during that time period. But overall, over the entire time period, there wasn't a difference in the risk of transfer.
Danielle, did you want to speak to that?
Yeah, that's right. So the significant difference that we found was that there was a 56% reduction in their risk of transferring to hemodialysis between that 3 and 12-month period. But the overall risk, I think there was a 21% reduction in the risk of a transfer to hemodialysis overall, but it was not statistically significant, and our confidence intervals were quite wide.
So that's really interesting. And so, Danielle, what do you think some of the reasons are for your findings? What do you think having support actually helps facilitate? Do you think that people that don't have support are at increased risk for complications and increased risk for transfer, or is there something sort of protective about having support itself?
Yeah, absolutely. So I think one of the interesting things about this study is that I think typically the way that support is looked at and studied in peritoneal dialysis often is from an instrumental support lens. And so, of people that need support, as we know, people that are on home dialysis often need a lot of support. And of course, we're not surprised by these findings. But oftentimes we make the assumption that maybe they need help with instrumental tasks like setting up their dialysis procedures and these types of elements. But I think what this brings to light is that really just having someone in the home is really important, and really just kind of emphasizes that it's likely that these support people are actually doing a lot more than these instrumental tasks, which are also important, but things like, informational support and emotional support and just these holistic elements of support that are also very important to consider. And so absolutely, I think, having support is critical, and how that support is delivered is critical. And the other interesting thing too is that people that had that support, they were more likely to have medical barriers and barriers to peritoneal dialysis. And so who knows, but it is very possible that the people that maybe have those and don't have support maybe aren't coming to PD, right? And so how do we kind of mimic that support?
Right. No, that's a really great question. A really good comment. Sorry. And it segues into my question. So if you were labeled in your study as PD with no support, did you not have a spouse at home at all, for example, or a family member? Or did you have someone who's like, I'm not doing this, like you're on your own here? But people did live in the house who could have been family members in the no support group.
Yeah, for sure. So the way that we defined it is that the person, it had to be someone at home. So it didn't even necessarily have to be family. It could be a roommate, it could be a friend, it could be whatever it might be, but that person had to be available and willing to provide support with PD. And so they needed to be kind of engaged with the PD process to some extent. Whether or not they were doing the instrumental procedure, it didn't matter, but they needed to be available and willing to help out if needed.
So in the no support group, do you know how many people were truly on their own at home versus had unengaged family or cohabitants in their home?
Yeah, that's a great question. I don't know the number off the top of my head right now, but I can look. I was actually surprised by how high it was actually of the people that didn't have that at home.
Yeah, and just as Danielle's looking at that there, I think, one of the comments to make was that when we collected this information, the way we define support really hinged on not only are you able to provide or available to provide support and willing, but you're capable of providing support. So there were situations where you'd have people who had, were caregivers for a sick spouse. In that situation, it wouldn't be considered support by our definition, just because they weren't capable of helping.
Right.
So there's a fairly tight definition, and it certainly left the door open that people in the no support group could have someone in the house, but they may not be willing to help out or able to help out.
Right. And I think that's a really important point, because one of the things I'm thinking about is, your study really does open a Pandora's box of so many other research questions. That what is support? What support is important? Mm-hmm. Is it actually doing the PD? Or is it actually being there emotionally for the patient? Because I'm thinking, okay, so if I'm the Minister of Health of my territory, I'm going to take your study and say, okay, we should fund an assisted PD program where people come into the home and help with the dialysis. But maybe that's not the support that was protective here. Maybe the support that was protective was all the other stuff around supporting a patient at home on dialysis. and wanted to know what your take, Danielle and Rob, were on that.
Yeah, no, I think that's very spot on. And I think that, it's difficult when, you need to make healthcare kind of decisions where it's like, okay, what one intervention, can we fund that's going to help solve this problem? And I think, part of the issue is that people have such diverse support needs, right? So for some people, having someone come in and perform the dialysis procedure and set up their cycler machine, might be exactly what they need. But for other people, they might be totally fine to do that, but they have tons of anxiety at home and there's lots of other things. So I think it is very need dependent. And so I think really the answer and part of what we need to be doing a better job of understanding more is the diversity of support needs that people have and how we can build systems that can identify and target these individualized support needs that people have and experience.
Yeah.
And I just add to that, Jeff, I think, one of the things I learned from Danielle during her master's work is she did a lot of qualitative studies around how people make this transition and their support needs at home. And it really opened my eyes as a predominantly quantitative researcher to the diversity of those support needs and the fact that we do a very poor job at kind of eliciting them in clinical practice and then putting interventions in place to support them. I think one of the challenges we've had in research is that it's very difficult to measure these things, and registries certainly don't contain this information. So very challenging to study, but I think extremely important.
Right. And to that point, as a question to you, Danielle. So one of the things that I hope people don't take away is not to offer people who don't have support at all at home PD, if they may stand to have a quality of life benefit from it or some other clinical benefit. But knowing what we know about the findings of your study, what do you think the right interventions might be in that group to help, attenuate some of those increased risks? And do you think it is actually sending somebody to help, or do you think it's, evaluating their social network and trying to see how we can support patients that might be marginalized or isolated from a social perspective?
Yeah, I know that's a great question. And a great point that absolutely just because someone doesn't have support doesn't mean that they're not, would be great on PD. And I think that really what this comes down to is shared decision making and really giving people the options. And if they want to do PD, regardless of their circumstance, like we need to do whatever is possible to support that person to be successful, right? And so, yeah, so I hesitate to give a one answer of that same intervention. And again, like I think it is just like what is really needed, as Rob was kind of saying, is really figuring it out what it is for that person and what they need, and they know best. And so really just kind of shared decision making and including patients in these conversations and learning from them about what they need and trying to put that in place. But from a program perspective, being able to meet that need when it comes. So understanding that we need to have a variety of avenues available so that when someone comes forward and say they have a lot of anxiety and you need to kind of connect them with a social worker or a psychologist or a psychiatrist, that person is available and accessible. And so, yeah, so it is about just having a program that can accommodate a number of different interventions for that person.
No, I think that's really great and really, really an important point. I'm going to switch gears in the last couple minutes to a methodologic question, one that I sort of get migraine headaches thinking about. If I'm not mistaken, in the support group, there was a higher overall mortality risk. Not that you modeled, but if you look at the proportion, I think it was a little bit higher. Does that make the fact that these people had a lower risk of transfer in hemo? How do we interplay when we're trying to look at risk factors for hemodialysis transfer and risk factors for mortality, understanding that these are two really important different events that are happening to our patient, to look at factors that are protective of both and looking at these different risks of mortality and transfer to hemo? As a researcher, and people are looking at all sorts of things, but what would be some of your thoughts around that complexity?
Sure. So, I think these are great points, Jeff, and what you're really kind of talking about from a methodologic standpoint are the presence of competing risks. So we're following people for an outcome, say technique survival, and along the way, they're at risk for dying or getting a transplant, et cetera. And it's important to account for those things, particularly when you're looking at the probability of an event happening, like transfer to hemodialysis. So when you account for those competing risks and you do it in a proper framework, unadjusted, that's a cumulative incidence curve that accounts for those competing risks. And that's a very good way of getting an accurate representation of the risk of the event happening. When you're looking at prognostic questions and kind of risk factors, using a traditional Cox model is just fine, because it basically tells you the relative hazard based on any particular prognostic factor and how that associates with your outcome.
And it's a really good point, Rob, because when we did our time on therapy paper in the PDOP study, I heard the same kind of thoughts. Why aren't you looking at competing risks when you're trying to identify risk factors for hemodialysis transfer? So I think that's a very well taken point. I'm going to switch gears because I've learned so much about this article. I think, again, the whole idea of support, what is it? How can we best facilitate dialysis at home and a more holistic view to support is what really, Danielle, I think, shed a lot of light in your paper. But I'm going to switch gears because I'm really excited that someone like you, who's a PD nurse, was clinical PD nurse, sort of delved into research. What kind of advice or mentoring do you think you could provide to all the nurses out there who may be somewhat interested in research, but a little bit nervous, a little bit, maybe it's not for me. I can't do this. Like, what do you think? Like, what would you tell people who are sort of thinking about nursing and research? Because it's really, really kudos to you for really pursuing your passion.
Yeah, thank you very much. That means a lot. And yeah, like absolutely, I would encourage any nurse and allied health professional and other people working within the system and patients to really pursue research. And I think that, it is so important, the different perspectives that we bring. And as nurses, we do bring a different perspective, and we see the healthcare system and we see and interact with patients from a different lens. And so I think that, there's a lot of power in having, nurse researchers and researchers of lots of different diverse backgrounds doing research so that we can bring these different lenses to the forefront of the research that we do. So yeah, just everyone working together to tackle problems, looking at things differently, I think is always a bonus. So
maybe the next research project is the availability of nursing support and research productivity among nurses. Because Rob, it sounds like you have been a really excellent mentor to Danielle. And of course, that obviously plays into, I'm sure your passion for research has probably permeated the program. So I just want to end things and say this has been really great, a really fantastic inaugural podcast. So I think we've learned a lot about support in PD and why it's important. I think there's a lot of important questions to ask about how we deliver that support and what that support actually looks like that makes a difference. And so I just want to thank you guys so much for your time today. And this is really a lot of fun and really great guests for our first PD Exchange. So thanks so much for joining us today. Please subscribe to PDI, and the article is by Danielle Fox, The Availability of Support and Peritoneal Dialysis Survival, a cohort study featured in this month's issue of Peritoneal Dialysis International. And thanks, Nikhil, for really getting this together. It's amazing.
No problem. And thank you, Danielle and Rob, for the lovely discussion and for being part of the first PD Exchange. This is Jeff and Nikhil signing off. Until the next PD Exchange. See you guys. Take care. Bye.